Today we're talking with Dr. Katie Greenzang, attending physician, pediatric oncology, Dana-Farber Cancer Institute, Boston Children's Hospital, and instructor at Harvard Medical School, about what's next, osteosarcoma survivorship. Our All Osteo Warrior panel today includes MIB Junior Board President Maeve Smart, MIB Junior Board Member Kara Skrubis, and MIB Junior Board Member Brandon Friedman. I'm your host, Anne Graham, President of MIB Agents. Welcome to OsteoBites, everybody. It's, as we've been discussing, such a gorgeous spring day. I just thank you for being here because who wouldn't rather be outside unless you have Dr. Katie Greenzang with you. So speaking of OsteoBites, I have my snack ready. I hope you do too. I have iced coffee and a little coconut bliss, which is super blissful as advertised. Today we're talking with Dr. Katie Greenzang. She is from Boston Children's, Dana-Farber Cancer Institute, and Harvard Medical School. She'll be talking to us about what's next, osteosarcoma survivorship. Such a great topic. Can't wait for all of it. But first I'll tell you about Dr. Greenzang. She is a pediatric oncologist at Dana-Farber Cancer Institute, Boston Children's Hospital, and an instructor at Harvard Medical School. Her research focuses on patient-provider communication and shared decision-making in children with cancer. She is particularly interested in understanding how families consider the short and long-term effects of cancer therapies when making treatment decisions, and how we can improve that communication about late effects of cancer therapy so that we can all be more prepared for cancer survivorship, which I think many of us didn't feel prepared for it. We were just hopeful for it. Our panel today includes MIB Junior Board members and Osteo Warriors Kara Skrubis and Brandon Friedman, and MIB Junior Board President and Osteo Warrior Maeve Smart. And I'm your host, Anne Graham, also an Osteo Warrior and MIB Agents Executive Director. There is so much to do to make it better. You don't have to be a doctor or a researcher to do it. You can, if you can walk or run or bike, you can do that for kids with cancer. You can also recruit your friends to do the same, create a team, challenge your coworkers, run solo. You could run on your treadmill, ride your Peloton, but just do it to make it better for kids with osteosarcoma. You can participate in outrunning osteosarcoma anytime from June 1st to August 31st. You can do a 5K, a half marathon, or a full marathon, or a combination of all of them over 3 months, but you have to complete it within the month. So you can't do a marathon over 3 months. So just gotta make sure you know that. Lots of friends, lots of families are doing this now as a group because we can. And Cleveland Clinic, by the way, is throwing down a massive challenge. Their team is outrunning osteosarcoma in the hopes that other institutions will join as well. Grateful for your effort in this and also the sponsorship of BTG Specialty Pharmaceuticals. Together, we can all make it better. Please register at mibagents.org/outrunning. While you jot that down, mibagents.org/outrunning, would you introduce yourself, Dr. Greenzang?
I'm Katie Greenzang. As Anne kindly said, I'm a pediatric oncologist at Dana-Farber and Boston Children's. Clinically, I spend my time taking care of patients with solid tumors like osteosarcoma and also of survivors of solid tumors. And I'm really delighted to be here today and to speak with all of you and learn from all of you.
Hi, I'm Kara Skrubis. I was diagnosed with osteosarcoma in January of 2020. In April, I went through a left above the knee amputation, and I am just finishing up immunotherapy.
Hey everyone, my name is Brandon Friedman. As Anne said, I'm also a Osteo Warrior and survivor. I was originally diagnosed in October of 2019, and I'm now living in Manhattan.
Hi everyone, my name is Maeve. I am a two-time osteosarcoma survivor. I was diagnosed in 2011 and 2014 and am now 7 years NED and a student at Northeastern University in Boston. Along with Brandon and Kara, I am on the MIB Junior Board and working in the Janeway Lab at Dana-Farber. I'm excited to be here. Thank you for having us.
Thank you so much for having me. I'm really excited to talk to you all today. And as I mentioned ahead of time, I'm happy to be interrupted at any time if there are questions, or we can chat more at the end. And I called this presentation, What's Next? Osteosarcoma Treatment and Survivorship. And as Anne so kindly mentioned, my research focus is really on improving communication and support to help patients and families make informed treatment decisions and feel prepared for pediatric cancer treatment and survivorship, with the ultimate goal of improving quality of life, and as you all say, making it better. And I'm really excited to get to chat with you all today and talk about this topic and share some of my work here. Some people wonder sort of how can communication make things better? And I think one example that's highly relevant to this group is surgical decisions in osteosarcoma. And in just chatting briefly with the panelists ahead of time, everyone makes different choices where this is concerned. And so for people with osteosarcoma of the limb, often they face choices between limb salvage surgery or amputation, or some people have an opportunity to have a rotation plasty. And this is a really personal decision to make. And people weigh a whole host of factors. This is a word cloud from our internal site describing the different options that might be available to patients. But in my own personal experience, helping to think through this decision with some of my patients, as well as in the research arena, what we've seen is that there's no one size fit all. There isn't one surgery that's a perfect fit for everyone. It's really about personal preferences and priorities and what's most important to you. And that people are happiest in the long run with the surgical choice that best fits their long-term goals. And that without knowing what the long-term effects and really hearing communicated quite clearly by both the medical team and sometimes by patients and families who've gone before them, people can't make the best choice for themselves. So I think this is a nice example of where communication about what to expect really matters in helping people make a choice that really fits for them. Here I have sort of the survival of osteosarcoma in more recent years, and we've made some advances compared to 50 years ago. There's clearly still a really long way to go, and a disappointing flattening of this curve in recent years. And many other people will talk to you about current work to try to improve this and do better with treating osteosarcoma. But today, I really want to focus on what are the costs of this current cures that we have available? What are the side effects in both the short and long term? And how can we do a better job of recognizing these, preparing people for them, and thereby trying to help people have the best quality of life possible? And so treatment for osteosarcoma is very well known to this group. Starts with chemotherapy and then surgery, and then often more chemotherapy, potentially with more surgery, with the goal of getting rid of all of the osteosarcoma and not needing more chemo. And we often talk at the beginning about this in broad strokes, but we all know that this all comes at a real cost. And in the short term, I think you can all describe much better than I can all of the side effects that come along with experiencing treatment, things like fatigue and nausea and fevers. And in the long term, there are potential side effects to our treatment too. And so in the long term, we think about potential health effects of treatment, and we call them late effects. And they're unfortunately quite common across pediatric cancers, and specific to osteosarcoma, our treatments carry risks of problems such as heart problems or kidney issues, hearing impairment, potentially second cancers, issues potentially with infertility depending on the treatment received, lung problems, musculoskeletal problems, and ongoing pain and neuropathies. And the thing is, these don't just impact health, right? They impact quality of life too. And so currently there are more than 10,000 survivors of pediatric osteosarcoma in the United States. And more than half have impaired health status in at least one domain, either physical health or mental health. And almost a quarter have some ongoing issues with pain, and a quarter can have activity limitations. And so what I like to think about is how can we do better at communicating what to expect from treatment in the long term, to both help people feel prepared for what's to come, because I think when we're ready for something, then we can think about what we can do to improve health and quality of life, and for people who face treatment decisions so that people can make the choices that are best for them. I also spend a lot of my time thinking about how we can learn more from patients about their own experiences of treatment and survivorship. And one way that we do this, and I'll talk about this a little bit more at the end, is through something called patient-reported outcomes, which is really collecting the patient's voice in clinical trials, because only by understanding what patients are experiencing can we really feed this forward and help make it better for future patients by helping them understand what to expect and to help with supportive care interventions. And so first, I thought I'd talk a little bit about what the current state of affairs is. What are some communications challenges and gaps? And I do this work first in talk about what parents experience and what parent priorities are, in part because many parents are some of the primary decision makers for their children, but patients have their own distinct priorities. And so I'll also share with you adolescent and young adult perspectives on communications challenges and gaps. I'll also mention that this work is actually done across cancer. So it's not osteosarcoma specific, but I think it has a lot of relevance in this particular disease as well. So first, what do parents say they want to know, and why is it important to them? In a study we did asking parents whose children are currently being treated for cancer what's important to them, we found that almost all valued information about late effects, starting right from the time that their child was diagnosed. And in part, they thought these were really important to hear about because they impacted their treatment decision-making. And unfortunately, only half really felt well prepared for potential late effects of treatment. And a quarter didn't recall being told that their child was at risk for any late effects of treatment. So why is there this gap between what parents want to hear and what they're actually hearing and feel prepared for? One reason is this is a really hard topic to talk about, right? It's as a clinician myself, I can tell you it's really hard to look a patient and family in the eye and say, you really need this treatment, but I'm sorry, it comes with all of these really tough potential issues. I wish we had treatments that had no side effects. And so I can only imagine what it's like from the parent and patient perspective to hear that these treatments that we're recommending can be harmful in their own way. And so unsurprisingly, almost half of parents say they find it distressing to learn information about potential long-term implications of treatment. But what was really interesting is that people who find this information distressing are actually more likely to value the information and more likely to want a precise understanding of their child's late effect risks. So whereas we providers may shy away from giving this information because we're worried it'll be upsetting, what parents tell us is, yes, it's upsetting, but more information will help me feel better, not less. And in part, I think parents find this information valuable and worry about these things because they worry about the impact on quality of life. And so we asked parents, and this is across a variety of pediatric cancers, how likely do you think it is for your child to experience these 5 specific late effects? How much do you worry about them? And how much would it impact your child's quality of life if they were to experience them? And what we found is the dark blue bars show how likely a parent thinks it is. And parents in general think it's not that likely that their child will experience these late effects, which for some is more accurate than others. And yet a disproportionate percentage of parents worry about these late effects. And I think a big driver of this is the light blue bars show impact on quality of life. And parents worry about these because they think they would be really impactful to experience. And why parents want this information is that they consider it important to their initial treatment decision-making. So we did a qualitative study where we interviewed a whole bunch of parents, and one parent said, "You're making a decision about putting all this stuff in him," referring to chemotherapy, "and what's it going to be like? How's it going to affect him when he's 30 or longer, you know?" So I thought about that quite a bit and had lots of discussions with the team. And when we ask parents what kind of information would be most helpful, that they tell us that it falls into really three categories. One is what's most likely. And so one parent said, "What I really want to know is statistically, with regard to my child at her age, you know, what can you tell me about what are we really facing down the road?" Parents also tell us they want information that's actionable. They want to know what they can do to either prevent a late effect from happening or to do screening to recognize it early to be able to intervene. So one parent said it'd be helpful to know what you could do to better your child's chances of not getting these other side effects. And lastly, parents tell us they want to understand the impact of the treatment regimen as a whole. At our institution, we often give people like a whole packet as an informed consent document that has like individual pages about each chemotherapy with the risks and benefits of each of them. And parents really want synthesized information. And so someone said, "But I'd like to know, with the cocktail of drugs that she got, with her current ongoing health problems, with the radiation that we're choosing, what is she facing?" So to just summarize this section, I think we've found that parents feel suboptimally prepared for and suboptimally informed about what to expect after cancer treatment. And yet they consider this information important to their treatment decision-making. So what about patients? So there are similar communication challenges and gaps for adolescent and young adult patients, whom I'm going to refer to as AYAs for the brevity. And so what do we know about AYA cancer treatment decision-making? Adolescents and young adults with cancer want to be involved in communication and decision-making. And yet studies have shown that they have many unmet information needs about topics throughout therapy and often don't feel as involved in decisions as they would like to be. And this is partly because of the unique life stage, which I think is well known to many of you, which is that so much is going on in your life as an adolescent or young adult. And a new diagnosis of cancer just steps you off of where so many of your peers are and where you're supposed to be. And this can be issues with body image, where you are in your career or education, issues of peer relations and health behaviors. So there are some really unique challenges. And yet, what role do AYAs want to have in decision-making? Well, you can all tell me that, but I'll tell you what the research shows is that people want to be engaged in treatment decision-making, often in conjunction with their oncologist and their loved ones. And that actually the younger the patient is, the greater the risk is that they don't have the role in decision-making that they would really like, that perhaps we as providers or parents don't offer them the opportunity to be as engaged in decisions as they might want. And one thing that can happen when your decisional role doesn't match what you would really want is that you can have some decisional regret. And in fact, about a quarter of AYAs with cancer have some regrets about their decisions. Those who are least likely to express regret are those who have more trust in their oncologist or feel that their oncologist really understood what was important to them. Again, sort of highlighting the value of having really open communication. What kind of information do patients want? Most consider prognostic information to be important. And those who have more prognostic information tend to have more trust in their oncologist, more hope, and more peace of mind, regardless of what their prognosis is. And in terms of my interest about expectations for the future, unfortunately, many cancer survivors experience at least one late effect of cancer treatment, and yet AYAs in particular have a lot of unmet information needs about late effects. And as a result, the studies show that many people are not fully aware of the risks of late effects. And those who are unaware of their risks may not be getting the care they really need in survivorship to help identify these late effects and treat them as they may arise. And as we've seen with parents, a similar trend is true with patients, which is that gaps in communication begin early. So more than 40% of AYA patients say consideration of late effects greatly influence their treatment decision-making. And yet, whereas 92% of AYAs say they got really high quality information about their diagnosis, high quality information about their treatment, and 86% felt like they got really high quality information overall, you'll see there's a big drop off with information about late effects, with only 57% of participants in this study feeling like they got high quality information about what to expect for the future. So I think we see similar themes in patients as we do with parents, though some unique considerations. And so AYAs with cancer tell us they want to be involved in treatment decision-making, that prognostic information and information about potential late effects of treatment are both valuable in their treatment decision-making, and that current strategies of information provision and support for treatment decision-making are really insufficient. So how do we do better? That's the question I always like to ask when I see some of this disheartening statistics. So I like to think about what we can do to improve communication and information. And there are a lot of ways to address this. One, of course, is that we can do better provider education. We need to, share some of these research results and talk about how do we tell providers that patients want this information. We need to do better at giving it. But I think that alone is insufficient. And so an area I'm increasingly focusing on is how can we develop interventions to really give patients and families the information and the support for decision-making that they want, that doesn't supplant communication with their oncologist, but instead supports it. And a third bucket I think about is how do we better understand patient experiences of treatment and survivorship so that we can really move this forward. So one way that I think about developing interventions is harnessing technology that we all use all the time. And that is particularly valuable, I think, to adolescents and young adults. It's just a part of life. And so the WHO definition of mHealth is the use of mobile and wireless technologies to support the achievement of health objectives. And so what we're thinking about is how to develop app and web-based resources to improve information and care during treatment and into survivorship. And so one example of what this might look like is I often think about our a typical information provision about this topic as we have at diagnosis, we have what we providers call the day one talk, the first day where we talk about a diagnosis and the treatment that's involved, and where late effects are perhaps briefly touched upon, but usually not the focus. And then we move forward through treatment and into survivorship and really don't often talk about late effects information in depth until treatment completion and survivorship. And I think there are a lot of challenges to that. First of all, as you see at the bottom, long-term side effects of treatment can actually start during treatment and can extend well into survivorship. And so we may be too late for some. And secondly, as I hope I've shown you with some of this early work, families and patients really want to take this into consideration when making treatment decisions at the very beginning. So this is too late. So we're working on making an app that could be shared with a patient and family after they have their first conversation with the oncologist, but still early in treatment, that can sort of tailor information to where their interests are and thereby meet patient and parent information needs and help people prepare for the future. And for people who are really facing a treatment decision, to help them understand the different aspects to that decision and what they may look like in the long run. Another way that we think about this is how do we incorporate patient experiences of treatment and of survivorship, and how do we understand these better? So I have recently been doing interviews with a lot of parents, and I love this quote that one person shared, which is that honestly, talking to a doctor is great, but talking to somebody who's already been through this is just so much more helpful, because they can tell you what to expect. Doctors can tell you what to expect, but they don't really know because they haven't really done it. And so I think we need to recognize our own limitations as providers, that we haven't lived the experience at home that so many patients and families have, and that we only see one small sliver of a person's cancer experience in the clinic and in the hospital. And so I think it's so important to better understand what's going on in life in and out of the hospital, both so that we can incorporate these perspectives in some of our interventions, but also so we can better tell families and patients what to expect. And so one way that we do this is called patient-reported outcomes, which are direct patient reports of a patient's experience of symptoms or of function or of quality of life. And there are some standardized measures that can be incorporated and collected to understand important aspects of patients' experiences of treatment and of survivorship. And these are increasingly collected in our clinical trials. So the idea is that to really understand what a treatment is like, especially if we're doing a study of a new treatment, we should incorporate this, and not just a clinician's approach of what they think a patient is experiencing, but actually capturing the patient's voice themselves. And so within osteosarcoma specifically, we can use this to understand patients' physical, emotional, and school functioning during and after treatment. It can be used to understand patient experiences of different surgical approaches or new treatments or new treatment combinations. And we do this by really trying to put this, as I mentioned, into clinical trials so that we understand sort of holistically the impact of a treatment. And I'm really excited to be working on some projects with the Children's Oncology Group in osteosarcoma specifically, to think about how to sort of incorporate these kind of measures in our standard clinical trials going forward, so that we can understand these important aspects of our treatment. So with that, I'll wrap up my more formal presentation and look forward to a conversation with all of you. This is just a thank you to my mentors, particularly to Jenny Mack, who's my primary mentor, but to all my mentors and supporters and collaborators and mentees, and also to all the patients and families who so generously lend their voices in this research so that we can make it better together.
That is the goal.
That is the goal.
Make it better together. I have to tell you, we have a program which many of our well, certainly Maeve is involved in, and a lot of our community members are involved in. It's called Ambassador Agents. Mm-hmm. And we have a licensed clinical social worker who leads the training. It's an 8-hour training. And we partnered with Amputee Coalition on the curriculum for this. And we train a caregiver and a patient. And so for example, if it were Kara, it'd be Kara and her mom would be trained ambassador agents. And then we receive requests regularly from patients and caregivers who just say, I just need to talk to somebody. Does anybody survive this? Like, what do I do about this or that? And the certified peer visitor from MIB will connect with that family, and their goal, and I say this regularly, humans should go through ambassador agent training, because it's such a great model where the caregiver and the patient, the former patient, the survivor, walks into a room, they give a 30-second, my name is Anne Graham, I'm an osteosarcoma survivor, I've been where you've been, how can I help you? How are you feeling today? Tell me more. And, they have a tote bag and, things that were informed by our junior board, things they wish they would have had when they were in treatment, same with the caregivers, things they wish they would have had. our feedback on this program has simply been like really great. Thanks for the tote bag. That's been awesome. Really all I needed somebody to do was walk in the room and say, I've been where you are, and walking off the street and look like a regular person who's living a regular life. And so that's been a really great program. And actually Maureen is on the call. So Maureen, let me know if you have anything else to add on that. But that your slide there really was an important slide, because when you're in the doctor's office, you know the clock is ticking, and you think about this disease all day long. And certainly when you're in treatment, this is all you think about. And so when you get in front of the doctor, you've just like, you got to triage your list, right? Because you only have so much time. But when you talk to another family member who's been trained to receive what you have to say and how you're feeling, and understand how much and what information they should be giving, is really important. So I am affirmed in that program by your slide.
Yeah, it's an amazing program, and I think so needed. And I wish that everyone with cancer could have that opportunity, you know, to have that systematized, because I think it's so welcome.
It's so welcome. And I'm going to let the panelists ask the questions in a minute, but I'll also add that along those lines, we have this book, Osteosarcoma: From Our Families to Yours, which, by the way, Alana Church helped us with, and our scientific advisory team. But it's a lot of information about osteosarcoma, but then it adds in information about from families to families, what I wish I would have known. So I think this is really helpful too, but we have so much farther to go. So this is really interesting. Kara, did you have a question?
I will ask one. Did you find that patients didn't really get the information about late effects up front, or was it more of a too much information situation?
That's a great question, and something we face a lot. Both patients and families have told us that they didn't get as much information up front as they would like. At the same time, patients and families also tell us that the very beginning is so overwhelming, and that it's hard to keep track of all of the information that's given in that upfront setting. And so I think that's one of the central challenges of getting better here, is how do we provide patients and families with the information they want, but in a way that is manageable and approachable during a really overwhelming time, both overwhelming in terms of information overload and basically learning a new language, but also so emotionally overwhelming that you can only hold on to so much at one time. And so that's where I actually think some of these apps and sort of electronic interventions that people can interact with on their own time and when they feel ready and go back to over time may be a nice supplement to the information that we verbally give, which can just be too much.
And I have a follow-up question in the same sort of sphere. So you emphasized how important, even though stressful, the day one talk is about, you know, the long-term effects. But, you know, sometimes the oncological team doesn't provide that. So do you have any tips of how a patient can kind of drive the conversation if they don't feel their team is, you know, giving them what they want or expect?
That's a great question. So, you know, in our perfect world, we all talk about this and we all ask questions, but sometimes for a variety of reasons, you might not get the information you need. I would hope that any oncologist would be open to the question of just, this sounds like a lot, and I really appreciate the information you have. It would be helpful for me to understand also, do these treatments have impact on long-term health? And if so, what are those and what can we do to help deal with those things? So I think just opening the question is the way to go, and nobody should feel offended by that. In fact, I think many of us providers don't talk about it because we're worried about upsetting people, and we feel guilty, right? That these treatments that we have are so imperfect in this way. we want better treatments too. And so I think we shy away from topics that make us uncomfortable sometimes. And so sometimes a family bringing it up on their own gives us permission, right, to talk about things. So don't be shy about asking that question if that's a question you have.
Similar, but we have two other questions in the chat that are asking, do you have information that summarizes what parents and patients should know? And how can a parent or patient know what to ask, especially as these two departments of oncology and orthopedics are both involved?
Yeah, we don't, I think, have a great summary sheet at this moment in time, aside from the treatment plans that I think many providers share with patients. And it's a great question about how orthopedics and oncology work together, specifically around surgical decision-making. At our institution, we try to meet together with patients and families and talk together so that we can all think about these questions. But again, just asking the question, I think we love patient and family questions, or I do specifically, because they help me understand what's important to people, and I can't help explain things if I don't know what's most important to you. So I think, again, just asking questions and asking if there are trusted resources. So even if there's not one perfect resource, if you're someone who likes to read websites or books, or asking for the resources that you want. Our group, for example, keeps a list of patients who've had different surgical approaches who are comfortable talking to other families. So if a patient or family currently trying to make a decision says, is there anybody I can talk to? We know who to send them to. So for example, a lot of resources exist, but sometimes people worry about bombarding people with resources. So sometimes you just have to ask.
How far out does the term late effect encompass?
Yeah, it's a great question. So we talk about long-term and late effects of treatment. Long-term effects technically start potentially during treatment and last. For example, people who develop hearing impairment from cisplatin, for example, that often doesn't get better. There are things that we can do to help, like hearing aids and things like that, but that lasting effect can last for the rest of a person's life. Late effects technically usually start after treatment is over, and they can also happen some of them happen at different time points in survivorship, but some can happen well into many years after treatment is over. For example, increased risks of heart problems, perhaps at a younger age, in people who got anthracyclines like doxorubicin, can happen years after treatment is over. And so this is why I think it's so important for people to know their own risks, because we need to empower people to seek the appropriate screening and care that they need in survivorship.
Another question regarding the late effects. Does the 23% of survivors that you noted have pain and 27% that have activity limitations include all pediatric cancers? For osteosarcoma patients, it seems like that number might probably be higher.
That's a great question. That was for patients with bone tumors. So that included osteosarcoma and Ewing sarcoma as well, but was specific to patients with bone tumors. I do think we probably under capture instead of over capturing, and we're also, much of our research only looks at a snapshot in time, right? And it's not following an individual over time. So there can be people who have pain at certain times, but then that gets better, for example. And that complexity is not captured in that kind of research. So I agree, there may be more people who are experiencing those things when we look over a longer period of time.
When you're in treatment, the hardest part is seeing the people that you love look back at you or look down on you in the bed and you can see the pain that you're causing, and not just the emotional pain that you're causing your family or your parent, or in my case, it was my husband, but there's work stress, there's sibling stress because the other siblings aren't being taken care of, there's financial stress, there's all of these pieces that are really a big struggle. And the reason I bring this up is because I believe that there are questions that particularly AYAs want to ask that they don't want to ask with the parent in the room.
Yes.
So, I mean, and I'm not just talking about like sexual function or fertility preservation or things like that, but there are things you want to know, but you don't want to cause your parent any more pain. I think there has to be some way where a patient can get one-on-one time with a physician or an expert, like a medical expert, because I think as young adults and certainly as an adult, you want answers. Like, what does this mean? What does this hearing loss mean? Do I have to get a hearing? Like, there are things you want to ask, but you're really afraid to ask.
Yeah. I completely agree that in my experience, there are a lot of unanswered questions. And I think that one-on-one time with an oncologist is critically important, because I do see this over and over again, that a cancer experience affects a whole family, and that patients, no matter their age, do things to try to protect their loved ones from what they're seeing. The aftermath of this diagnosis is in all different areas of their family's life. And one way we protect people we love is by shielding them from information that's upsetting. And so I completely agree. I think one thing I always try to emphasize is that there's no one perfect conversation. This is a whole series of conversations over time. The best communication happens over repeated conversations and by providers really making themselves seem like a trusted and open person to a patient and family, so that when a patient or family feels ready to ask their question, they feel comfortable asking it. And so in an ideal world, because that's the other piece, I think not everyone's ready to ask their question in the moment it pops into their head. Sometimes, in my experience, people need to think about it for a little while and think about how they want to frame it and when they want to ask it and of whom. And so I think we as providers need to be really mindful of that, in both finding time alone with patients and in keeping doing that, because the first time you do it, you might not get all the questions that someone really wants to have. And it's only by checking in frequently and creating the space for those that you can really create the space for all the questions to be answered.
My other thought while you were talking is, with the book, we get such positive feedback on this, and people, it's over 100 pages, and people say, I read it cover to cover. And it was because it's a lot of information that you want, and you can do it at night. It's not a conversation where everybody's present. Like it's you're in your own space reading it. So I think it's not unlike a teacher, right, who has to figure out what's the best way to teach this child. Is it audible? Is it tactile? Is it reading? Is it in a group setting? What's the best way to go about this? We would be delighted to collaborate on a patient information card system. And I'm going to add to that. It would be great to have because I know this caused a lot of stress. I know for Maeve, I know for me, when you get moved over to your primary care physician, you need something to not just, because they'll look at you and they go, oh, well, you look great. And it's like, I have so many things to do. Like, and you don't have the time to say, this is what I had. This is the medication I was on. This is the chemo I received. These are the long-term effects I'm having now. And here's what you need to look out for. Be really great if you could just hand that to somebody, to your primary care physician, and feel good about leaving the oncology center and get to the next thing.
Yeah.
So.
I would love to learn from all of you and incorporate all of your voices into that kind of resource, like a one-page sheet. I will also share that there are some existing resources, because I think oncologists have recently realized this issue as well. And so a lot of individual centers have their own sort of way to print out and share sort of a treatment summary to share with other providers, but also there are increasingly some tools available on the web that help patients own their own treatment summaries or sort of input their own information, like survivorship care plans. And I'd be happy to share those resources if that would be helpful for people.
Actually, Anne Raymer, thanks very much. Anne is pointing out, and we had them on OsteoBites last year, Passport for Care. They're brilliant. I mean,
yes, that's the one I'm thinking of.
Yeah. It's so good. Thanks, Anne. That's really, it's such a great resource. We just gotta, I don't know, let more people know about it.
Yeah.
But also it'd be great to have it on a card and hand it over.
I have a question. In your presentation, you mentioned that the more that the decisions are driven by the patient, the happier the patient and the family, the outcome will be throughout. But for pediatric diseases, when the patient might be anywhere between 8 to 13, and I'm not even sure legally who has the jurisdiction with parents over treatment, how do you find a fair balance between the patient, parent, and the decisions that have to be made, while also adhering to what you said about the patient driving?
Yeah, no, great question. I would clarify that most patients tell us that they don't, especially adolescent and young adult, and in some research in younger children tells us that they don't necessarily want to drive the decision so much as they want to be a part of the decision. And so I think we can make really any age child a part of the decision. And it's all about, sort of, to use Anne's teaching analogy, thinking about how to make the information appropriate for the age of the child. I think when we try to protect young children or even adolescents from really hard news, sometimes instead what the patient feels is that there must be something really terrible that everyone's keeping from them. And they may expect that things are worse than they actually are, because it's so horrible, it's unspeakable by their parents or their care team. So I think the more we are transparent, regardless of age, about some of these choices or what's involved, the better we can do. Now, I'm not saying that you ask a 3-year-old, do you want chemotherapy today or not? Because that doesn't really work. But I think we can give people agency over certain decisions, no matter their age, and make them at least feel a part of the process. And so we think a lot about how to do that at different ages. And with younger children, it might be just making sure they know the name of their cancer and why we're asking them to do all that we're putting them through. And that in and of itself can give them a sense of agency. And then with older patients and families, of course, then it's really involving in all the nitty gritty if a patient wants to. But our general practice is to really ask a patient and family, how do you guys like to navigate decisions like this as a family? Do you all want to be involved in everything? And some patients, no matter how old they are, say, I really don't want to hear all of this. Talk to my parents and let me know later. And that's fine. And this again gets back to sort of what we were talking about before with when you can ask these questions. For a patient or a family, I never presume that what they said at the beginning about their information preferences is static and stays the same all throughout treatment, because they may evolve and change, especially as patients grow up, right? And so what you needed when you were 8 is really different than what you need when you're 13. And so I think we have to just do better at asking what works for your family. Here's what we see in our experience about communicating, and then work together as a team.
The discussion today on late effects was mainly like physical regarding like secondary cancers, cardiac toxicity, hearing loss, but not so much more so like the mental health risks that can come with survivorship, like anxiety, depression, PTSD. So is there data that you're doing and collecting as well in terms of like the prevalence of these mental health things in pediatric cancer survivors? So like future initiatives, in addition to kinder treatments, of course, can better support survivors in the meantime as well.
That's a critically important question. So definitely we know that cancer can not only have negative mental health impacts on patients, but also on the whole family, and that parents of children with cancer can suffer from anxiety or depression both during treatment and afterwards. And so this is a really important thing, and part of what I was getting at with quality of life. And so I think the way we're trying to better understand this is in part some of those patient-reported outcomes I was mentioning that we can collect from patient voices directly on treatment trials and in survivorship. Many of those ask and have screens for anxiety and depression or other mental health effects of treatment. And so it is critically important and often not discussed enough.
We just have a few questions. If there are any reference or resources available for treatment options or surgery options specific to osteosarcoma.
Like existing websites or tools or things like that? Is that what the?
Yeah.
I know that there are a lot of individual centers will have websites devoted to example, like what the different surgical options entail, but I'm not that familiar with tools to help guide a family through a decision. And I know that there's been work done in this arena, and I've been lucky to sort of help think about that with some people, but to my knowledge, there isn't really an existing great tool. And that's what I'd love to keep thinking about with all of you, is what kind of information would you really want, and how do we represent the patient voice of what all these things feel like to experience? Because I think it's needed.
We have a new thing on our website, and this is not typical where I talk about MIB the whole time.
No, I love it. I love it because you're filling the need, right? Clearly there's a lack here and you found a way to fill it.
In MIB, we're kind of a clearinghouse for, you know what I wish I would have had, and we try to figure that out, because if one person wished they had it, I know many people did. So we just launched a platform within our website to find an osteosarcoma specific clinical trial. And you can, if you've ever gone on clinicaltrials.gov, it is comprehensive, but it is intimidating, and you can get all the way through the vast listing of everything that clinical trial includes, and then find at the bottom that you have to live in Tanzania or some crazy thing. So we have on our website this platform. It's specifically only for osteosarcoma, and you put in a few bits of information, and within 60 seconds, it brings up all of the clinical trials that you are eligible for, are in your area, et cetera. So if that's what you're looking for, I'm pleased to tell you, this has been such a great addition to our website and to our armory of things that we can do to help make it better. And I really think it's possible that it could help improve your outcome if you know that a clinical trial exists for you.
Yeah, that's a great point. That's a tremendous resource.
Yep, it's a big one. And then the only other, and it's not even that's not even medical advice. It's a platform to filter through clinicaltrials.gov. But the only other thing that we say as MIB agents is get to a sarcoma center, even if it's just that the sarcoma center rides shotgun on your home hospital or your home care facility. You need to get to a sarcoma center and get an expert to get another set of eyes on a sarcoma. there's another way you can make it better for kids with osteosarcoma, and it's through outbidding, it's through shopping, you guys, it's through an auction. It's in addition to outrunning osteosarcoma, you can outbid osteosarcoma from June 7th to the 13th. You can bid on travel, art, spirits and food, experiences, both virtual and in person. This gorgeous platter behind me is one of the items. It's made by my friend, Miranda Thomas. Miranda is a renowned potter based in Vermont. Her pottery is collected in hundreds of homes, including those of celebrities and dignitaries. She has designed diplomatic gifts for President Barack Obama, Vice President Joe Biden, UN Secretary Generals Ban Ki-moon and Kofi Annan, and the Clinton and Obama administrations, and for Pope John Paul II. Like, she's amazing, and she does just brilliant work. We have so much good stuff like this, baseball experiences that will blow your mind, just really great stuff. If you have something of value to share with outbidding, please let us know ASAP. It's got to be good though. So get in touch. You can email me, ann@mibagents.org. So that's it on outbidding. I'll stop talking about it, but we have so much good stuff. Next week, we're taking a break in honor of Memorial Day, and the week after that, we're off as well. So we'll be back on June 10th with a much requested and much needed talk with Julie Lanford, author and oncology dietitian. Her talk is on nutrition and cancer, truths and myths. Like, does sugar feed cancer, or does juicing make sense? Like, don't you want to know the answer to those questions? Like, I am so excited. I have so many questions for her. So thank you for joining us today. And of course, thanks to our guest, Dr. Greenzang. Thank you for sharing your time with us today and for undertaking the important work you do. We have more to talk about, so much more to talk about, but we'll come back to that. Thanks also to our panelists, Maeve, Kara, and Brandon. And we'll see you all June 10th. Thanks, everybody.